Good evening, everyone. Thank you for having me tonight. It's a pleasure to join you guys talking about breast reconstruction. And we hope by the end of this presentation, we'll be able to demystify what we know, to learn new concepts, and as emerging surgical leaders, medical leaders, hopefully we'll get more information and be able to advise our patients on this important subject. Thank you also for inviting me to talk about breast issues in the month of October. We can never underestimate the impact that breast cancer has in the whole world, actually. It doesn't matter what race you are or where you stay. Breast cancer affects a lot of women and a few men around the world. Thank you also, Ila, for the work you're doing. That's quite impressive. So without further ado, I'll go into the presentation. So what is breast reconstruction? This, according to the Cancer Research UK, it says breast reconstruction is surgery to make a new breast after removal of a breast or part of a breast. So the aim is to make a breast of a similar size or shape to the original breast. But I found something interesting that they indicated that, but even if we try our best, excuse me, we can never really get to the original breast. And that's very important for patients to understand, because I usually get this question to say, am I going to get the breast the way it was? The truth is no, but we can get as close as possible to the original breast with very successful results in some patients. However, in plastic surgery, we look at breast reconstruction as being a huge umbrella beyond the removal of a breast after cancer. So some conditions like tuberous breasts, gigantomastia, gynecomastia that we'll look at this evening actually do constitute what we call breast reconstruction. We call it breast reconstruction because actually it's not cosmetic. It's not considered cosmetic. Other procedures, like I heard people talking about from the survey that you did a few minutes ago, people are talking about breast enlargement and breast lifts. All those things constitute some kind of cosmesis. However, in this case, these reconstructive procedures are actually not cosmetic. So what's the scope of a problem? What are we looking at? So breast cancer causes deaths globally. This is statistics from 2022 that say up to 670,000 deaths. That's over 500,000 of people died in 2022 due to breast cancer. That's quite a huge number. And roughly half of all breast cancer occurs in women with no specific risk factors other than age and sex. Okay, so we're talking about the scope of a problem. So we talked about the number of patients that are dying globally every year, more than 500,000. And then we roughly these patients with no risk factors, that's very important, because I mean traditionally we are told, I know some of you are medical students, you're told either there's a family history or all those early menarche, late menopause, but we see patients coming in the recent years with no specific risk factors. These are young patients in their prime of life having breast cancer. So that's very important to note. And this is more true in the Black population. So breast cancer was the most common cancer in women in 157 countries out of 185 in 2022. Again, I'm looking at 2022 statistics. This is from WHO. And of course, we've said it occurs in every country in the world, regardless of race. And we will not forget to mention that there are men who do get affected with breast cancer. Although the percentage is small, when it occurs in men, it's usually more adult. Quickly, what do you expect if someone comes to you in the clinic with the breast cancer, or someone who's going through some symptoms? So it can be a combination of symptoms, sometimes very subtle, but the more advanced the disease is, of course, the more overt the symptoms will be. So sometimes it will just be a breast lump with or without pain, usually without pain. Changes in the size, shape, and appearance of the breast, dimpling, redness, pitting, and other changes in the skin. I've put a Pew Derange classical textbook picture on the right, showing a breast with obvious changes of, there is a retracted nipple, and you can see the skin changes that have occurred on the skin. And also sometimes patients will tell you they have an abnormal fluid coming from the nipple. So again, just a summary of that. At times you may get a mass in the axilla as well, and thickening and pain, discharge, erythema of the skin. So for the workup, of course, you would have done, we know triple assessment is examination, any investigation that you can do, and then there's a biopsy, which is almost always warranted for you to confirm that this is actually a breast cancer, because other diseases can mimic breast cancer. So patients younger than 30 years, we know usually we do, some textbooks say 35 years, so usually you do an ultrasound. Those above that age will have a mammograph done as a screening procedure before you go in for a biopsy, just to try and rule out any disease process when the patient comes with some kind of complaint. So in terms of a treatment, and I think this is important that we talk about it because it has an impact on how we are going to reconstruct this breast after a diagnosis of breast cancer has been made. So there are many things that can be done, and this is really based on the stage of disease. When it's very early, it's very possible to do what we call breast conserving surgery. That is where you just remove part of the breast and the affected tissue, and then you reconstruct that, either immediately or later on. Sometimes with or without going to the axilla, depending on whether there are nodes or not. Then there's also hormones. We know that breast cancer, of course, I'll not talk about this in this presentation, but just for our information, is important to know that there is breast cancer that's sensitive to hormone, or the hormone receptors are present on the cancer itself. So then we can give hormone therapy to treat the patients. Then we can also give chemotherapy, and also there is role for radiation therapy, especially in the early stages in patients who you do breast conserving surgery. The more severe surgery that we do then would be removing the whole breast. Previously, they would even remove the muscles, which is the pectoralis major and minor. Now it's not done. Mostly we just remove the breast tissue itself, and then the patient goes for any other additional adjuvant treatment. So this is just a picture of a patient I got in one of my clinics, a 65-year-old female with bilateral mastectomy. So I just brought this to just show us that, sometimes you just think about breast cancer affecting one breast. She actually had breast cancer in the right breast, and she actually opted to have the left breast removed as prophylaxis. So again, this I already talked about what we do. Either you do surgery, partial removal of the breast, or total removal of the breast, hormone therapy, chemotherapy, radiation therapy, as a summary of what I was talking about previously. Then post-mastectomy. So we have this patient who's had a breast cancer diagnosis. They've got their treatment. Then what next? What happens? So this is a picture you see in the clinic. A patient will come. She looks okay when she's dressed, but the moment she removes her clothes, then you tend to see what the real problem is and what's really going on within. So you can see on the left, this patient came in after mastectomy. You can see she has a device on the left to try and just fill in the gap after the loss of her breast. So what we need to know is that breasts are actually important parts of a woman's body in terms of secondary sexual characteristics. They, define womanhood, attraction, self-confidence, all those things that make people, function and interact socially every other day and within their families and so on. So you find that post-mastectomy, most patients will have this negative body esteem. Can be due to the treatment, the cancer itself, the stigma. Sometimes there is fear, there is hopelessness, there is depression. And for this patient who tells you every day she has to wear prosthesis just to look normal and to look like every other woman out there. So I think it's something to think about. So that's really why we're having this discussion today. So what are we going to do with our breast cancer patients after they've had their treatment? Then we think about it in a multidisciplinary kind of a way. So it's not like it's only the plastic surgeons or the general surgeons who treat this patient. It's very important to think about this treatment as involving, oncological surgeons, the ones who remove the tumor. Then there's, us, the reconstructive surgeons who are coming in to fill in the defect that's been left after cancer removal. Then there's a radiologist who's going to tell you, we talked about MRIs, ultrasounds, and mammograms that you're doing. The pathologist who will tell you, are the margins negative or not? Is this patient actually cancer-free before we start thinking of reconstructing? The radiation therapist who's going to give radiotherapy, medical oncologists, guys who are going to give a chemotherapy, and most, we overlook this as psychosocial cancer now, because after the loss of this breast, how does this patient reintegrate into society, and how do they move on with their life after what has happened? So how would we classify breast cancer reconstruction? Think about it in this way. So what are we going to use to reconstruct? So basically, we can use implants. I hope most of you have seen those implants either on the internet or on those TV shows. Tissue expanders can be used as a temporal measure before you put the implants. Then we can use flaps or parts of our own bodies, also called autologous tissues. So where you move tissues around from other parts of the body. And we can also do fat grafting. So also think about breast reconstruction in the sense of when do we reconstruct? So there are two ways to think about it. It's either you do the immediate reconstruction, meaning on the table, you remove the cancer or the tumor that's there, then in the same sitting you bring in some tissues, or you put an implant or a tissue expander or something. Yeah. So the advantages and disadvantages of this, if you do it immediately, of course, for the patient, it will be one procedure, so removal of cancer and reconstruction. But then there's a downside, because we said if you do breast conserving surgery, meaning part of the breast has been left, and then you reconstruct in the same sitting, the patient almost always has to have radiotherapy. So that means, the appearance of a breast will probably change, because radiotherapy will damage most of the tissues. So it may be a drawback in that sense. But you can also do what is called a delayed reconstruction. That is, after you've taken out the cancer, send the patient to the medical oncologist, let them finish with, the chemotherapy or the hormonal therapy that they need to go through. Let them see a pathologist again, or rather let someone confirm that they're actually cancer-free. It can even take a year and a half, even up to 3 years before we get to that point. Then the patient will have a confidence to say, you know what, I had this cancer, I'm out of it. Can I now get reconstruction? And that will be called a delayed reconstruction. So on the right is just an image showing you one of the most common flaps that we use. This is called deep inferior epigastric perforator flap, that can then be raised and placed on the breast that has been removed. Either, usually this is done using microsurgery, but we can also do what is called a tram and other kinds of flaps. Yeah. So really it depends on what the patient wants, and also the other treatments that the patient has to receive before we get to breast reconstruction. So this is an image of a patient that we had in our unit. So you can see before with her post-mastectomy scar on the left side of the chest. So what we did is we raised a tram, a transverse rectus abdominis musculocutaneous flap, that we raised and placed on the left side. So this is kind of good for most patients who have some kind of redundancy of tissues around the abdomen. You actually give them a tummy tuck in the process of doing that. So later on, of course, you have to come and reconstruct the nipple. Also good to appreciate that on the right side, we've actually done a breast lift just to try and symmetrize the two sides. Then we can also do fat grafting for, actually it's the same patient, came later on. We wanted to add some volume to that. So basically, again, we go to the abdomen, we do liposuction, we centrifuge the fat and get the stem cells that we need, and we inject them, and with quite good volume replacement. So what do we think about? You guys, the challenge, we can challenge ourselves tonight and just think, what's the future of breast reconstruction? With all the options that we've been given, then we need to start thinking there are other things we can do. So of course, we're already doing microsurgery, but we need more microsurgeons. We can do super microsurgery, which is also an exciting field that people can go into and see how we can safely perform most of these procedures. Then of course, with our diagnostic radiology, we can do more there. Molecular genetics, tissue regeneration, also another exciting field where we can, find better ways of breast reconstruction techniques. Is an image of a patient, a typical patient with gigantomastia. So what are the indications of, surgery? Before we do surgery for these patients, what do we look at? So chronic back pain, neck pain, shoulder pain. I want you to appreciate the shoulder grooving from the straps in this patient, as indicated on the top right or left of the patient anyway. You can appreciate that. That's from the weight of carrying huge, heavy breasts over time. Then sometimes they get this chronic rash under the breasts. Sometimes they get pain. The breast can just be painful most of the time. And usually the patients will tell you they're not able to, you can't run the normal way with a weight on your chest. And of course, then you can't fit in normal clothing, and, the self-image that is distorted due to the weight that the patient is carrying. So in essence, we don't look at breast reduction as cosmetic. It's actually reconstructive because of the above reasons that we've given. So I'd give you a typical patient like this patient. This anatomical compensation, sometimes our patients get kyphosis, they get muscular distortion, and even bony changes from either the shoulders or from the spine. So you can see this patient on the left with a bra. Some people may think she looks okay, but the moment she removes her bra, we can see how extensive that the mammary glands are reaching beyond the umbilicus, which is quite abnormal, isn't it? Yeah. So you find even when she's wearing her bra, she's really trying to lift. I don't know if you can appreciate that lift of her shoulders to try and support the weight. And of course, there's that shoulder grooving, in a patient with very severe disease. So in this patient that I showed previously, we excised about 12 kilos. Each of these breasts was like 6 kilograms that were excised. And of course, this is immediately post-op, still on the table, intubated. You can see we've put in our drains to manage the wound post-reduction. And this is just a before and after. This is 1 year post-operative. Patient is satisfied with the outcomes. Most things have healed, but of course there's a bit of scarring. So a study was done, although it's been quite a while. Many studies have been done after Mazzochi and his colleagues did this study on the posture changes after breast reduction. So they followed up patients who had breast reduction, and a year later they did measurements that they had done initially to see how these patients' posture has changed, either when sitting or even walking. And they actually realized that these patients do have a significant change in the way they walk, in the posture after breast reduction. I don't know if I mentioned the contraindications of breast reduction. So when do we decide not to do breast reduction? So in patients who smoke, smoking is a contraindication because, of course, you get severe or you're highly likely to get complications. Then very obese patients with BMI over 40, most units will want to get the patient to a normal BMI before, or near normal, before they can operate on the patient, just because with the higher BMI is associated with higher risks, things like clots and also wound breakdown and so on. And also, if a patient tells you, you know what, I want a breast reduction, I have all these symptoms, but I don't want any scars on the breasts, then obviously you know that that's not possible. We are not magicians. The reality is you will have scars on the breast. So those are some of the conversations you should really have with your patient before deciding to have surgery. And then there's the issue of having children. So how does breast reduction, relate to breastfeeding afterwards? So I find sometimes patients are still in the childbearing age and they tell you, I want to have a breast reduction. So I always have a conversation with them. Then first of all, you need to find out how's the breastfeeding now. You find some patients have such huge breasts that despite the size of their breasts, they actually don't produce that much milk. Yeah, maybe due to the engorgement of the ducts or something or any other factor, they're unable to breastfeed like the normal patients with a near normal size breasts. So the conversation then should be based on the studies that have been done so far. There is no conclusion. There are varied results. Sometimes the milk production, can remain the same. It can increase or decrease. And that's really based on what was done during surgery. So if during surgery you manage to preserve the ducts as much as possible, meaning you don't dissect so much below the areola, then you're likely to get the patient to continue breastfeeding in subsequent pregnancies. Also, a patient who's kind of planning to lose weight. So they come with a certain BMI and they tell you, I would want to get smaller. The best advice is tell them to wait until they're at the ideal weight, then they can get surgery, because you definitely know if you operate, they lose some weight, they'll lose volume, they may have to have some revisions done over time. Yeah. So this is just the patient photos the patient sent me after a while. That's like almost 2 years down the line. Very confident. From on the left side, being unable to wear normal clothes to, being able to put on t-shirts and having the confidence back. She's really smiling and very happy with the outcome. Yeah, so we can talk about gigantomastia. Gynecomastia, my bad. So gynecomastia, also known as man boobs, it can affect one or both breasts. It can affect men of different ages, from the newborn all the way up to, the old age. Sometimes patients may have associated pain and tenderness, and even sometimes social embarrassment, due to the fact that they are males and yet they come with, features that are kind of feminizing. So this is just a photo of one of my patients with quite high, an advanced stage of gynecomastia. So what are the causes of gynecomastia? So there's what we call physiological gynecomastia. This one occurs during times when the body is going through some hormonal changes. So from birth, it's not abnormal to get a child with breasts or gynecomastia, and even producing milk. We know that the maternal estrogens are still circulating. That's not, really abnormal, because we know the physiology behind that. In adolescence as well, it's not very abnormal, because we know that there is some kind of shift that's going on as the increase in testosterone picks up, but then we also know there's a lag in estrogen, and that interaction can also cause some kind of flare up in the size of the breast. And also for men above a certain age, usually 60, 65, they may come with gynecomastia due to the changes in the hormones. So those of us that love mnemonics, there is this codes. So commonly cirrhosis of the liver, obesity, digoxin, which is a drug, estrogens, anything that can affect or increased estrogen can cause gynecomastia. Spironolactone as well can cause gynecomastia. Also, we have genetic conditions like Klinefelter, where you have an extra X on an XY individual. Medications, including some antibiotics, like mentioned here, some anti-ulcer drugs mentioned here. Also, HIV medication can cause that. Diseases, we've talked about liver cirrhosis and pneumonic, but thyroid and testicular cancer and kidney disease can also cause gynecomastia. Lifestyle choices, things like taking alcohol, recreational drugs like marijuana and steroids can also induce some kind of gynecomastia in males. So aside from this, which is age-related, the rest of them are considered to be actually not physiological. This is like a pathological. So it's either you change the drugs or you cancel the patient to say because of what they have, then it's causing the gynecomastia. So what do we do for gynecomastia patients? We do liposuction to assist with the excision. It makes the surgery way more easy. So we start with sucking out the fat, because we know that around the gland itself there is some fat that needs to come out. And then we do surgical excision. Sometimes we do both or either one of these things. But surgical excision is almost always mandated. Then this is just a pre and a post-op of a patient, a young patient in his 20s with this gynecomastia. Patient will tell you they can't take off a t-shirt, they can't swim, they can't, sometimes they're putting on a shirt. You know, this patient is quite lean, so it's very easy to see what's going on. Yeah, and that's the post-op. So I think we'll end the discussion there. I currently practice at Moi Teaching and Referral Hospital for those of us joining outside Kenya. Yeah, and so you find our plastic surgery practice there. We usually do a camp every year around February or March, where we do most of these surgeries. Yeah, thank you so much for joining. Back to you, Jesse.
Wow, just wow. It's been a very wonderful journey into the world of oncoplastics, and I must say it's very fascinating. Like the science of it, also the humanity in it. And I think also our members have the same sentiment. So I just like to let the members share their questions for Dr. Nangandu. If there are any, you can unmute, or you can also drop them on the chat box. As the members are putting their questions or perhaps thinking about it, my question to Dr. Nangandu is oncoplastics or these procedures available through public insurance funds? Is it something that you can get through, like for example in Kenya we have the NHIF, now the SIH? Can it be provided for patients?
That's a good question. It's a bit of a struggle because of course the perception out there is that this is cosmetic. Funny enough, there are some insurance companies that will pay for gynecomastia, which is the one that occurs in males, but they will, you know, for breast reduction, some insurance companies are not very eager to cover that. Sometimes NHIF will cover in certain hospitals. The criteria has to be that it has to be done, I think, in a level 6 hospital. So if it's being done in any other facility, it's a bit difficult to get pre-authorization for that. So even in the States, you find insurance will only pay for reduction of a certain weight. So below 500 grams, if I'm not mistaken, then insurance will not pay. The patient has to pay. Yeah. So, sometimes someone will have 600 grams. For them, that could cause all these symptoms. In another patient, they could easily carry 1,000 grams on their chest with no problem. So it's a bit of a difficult and a bit controversial topic. Yeah.
Yeah, thank you very much. There is also a question from Alice who wants to know if breast reduction equals no breastfeeding, or there can be duct sparing breast reduction.
So I think I had mentioned in one of the slides that it depends on. So right now we don't have. You can't say yes or no because we don't know how breast reduction affects a patient. So I was trying to explain that some patients have very huge weights in their breast, or the breasts are very big, but they're unable to produce enough milk. But after breast reduction, some report an increase in the production of milk. For some, they can experience a reduction after breast reduction, as in reduction in the milk production levels, simply because of maybe what the surgeon has done, because there are many ways of doing breast reduction. So sometimes you find the ducts are completely cut off, or some method that's used that completely cuts the connection between the breast ducts and the nipple. Yeah, so it depends on what has been done. So the answer is, it could be a yes or a no, depending on what you've done, depending on the patient we are looking at. Yeah. But you find for most patients, it's actually quite bothersome to continue carrying. Like now, the patient I showed you is 12 kilos. I don't know, between breastfeeding and carrying that weight, I think most patients would rather just have it removed, because the quality of life then improves, as studies have shown.
Okay, thank you. As we have time for one more question. So I see Shirley has asked, does the drugs you listed cause an irreversible damage once the patient withdraws from it, the breast size returns to normal? So I think they're talking of the gynecomastia induced by drug.
Yeah, thank you for that question. So it depends on the stage, because gynecomastia also has stages. So in the initial stages, it's actually reversible. Like, for example, the cases I've talked about where in a neonate, if you withdraw the estrogens, then the breasts go back to normal. In adolescence, once the testosterone peaks, then you find the male children have a return to a normal, like a reduction in the size of a breast. But if, for example, you've been taking a drug for so long and the breast has already reached the fibrotic stage, unfortunately, then it's not reversible. So it depends on how long the drug has been used and whether any fibrosis has occurred within the breast. Because once those permanent changes occur, they will not regress. Yeah.
Okay, thank you. As we conclude, I'd like to maybe ask Dr. Amanda if she can comment about the state of African breast reconstruction resource and capacity. Is it something that is available in Africa in all settings, or is there some challenges that still need to be countered in order to make it freely available to all and everyone?
So my thoughts on that would be it's twofold. The first aspect is on the society or the communities from which we come from. It's kind of a shameful thing. Most people are not really willing to come out in the open about what they're going through. For fear of being judged, of course. Even for the males with the gynecomastia, they would rather pad or do something to hide it than come out in the open, because people will ridicule them. So the perception is, you're exaggerating this, you don't need this surgery, which is already a hindrance to, accessing healthcare. The other part of it is when you come to the hospital, we don't have enough people who can safely do breast reductions. I mean, in most countries, but the numbers of plastic surgeons now has increased in most countries. So you find public hospitals now are beginning to do breast reduction procedures for patients, especially where insurance can take.